make sure I don't go over time. Okay, so today I will be talking to you about determinants of antenatal screenings for prevention of congenital syphilis and HIV in Lusaka, Zambia. So when we talk about prevention of congenital syphilis and HIV, the best way to go about it is to screen pregnant women to be able to detect the infection and treat as soon as possible in a timely manner. Okay, and so for my presentation, I'll be covering two studies that I was able to conduct, one cross-sectional study and another systematic review. This talk will mainly focus on syphilis, but will also include HIV outcomes in the first study. Okay, so my research is mainly focused in Lusaka, Zambia, and the greater sub-Saharan Africa region, but it's also very important right here at home. The CDC just released that there were double in number of cases from 2013 in terms of congenital syphilis. So it's increasing in the United States. Syphilis in general is on the rise. I think the largest group is MSM that it impacts. And it's a preventable disease, so it's very relevant right here at home. Talk about. So a little background regarding syphilis during pregnancy. So having maternal syphilis can increase mother-to-child transmission or vertical transmission of HIV by twofold. Adverse pregnancy outcomes are 12 times more likely in untreated pregnancies. Untreated maternal syphilis accounts for up to 1/4 of all stillbirths and 11% of neonatal deaths globally. And even so, infants then surviving with congenital syphilis end up being of low birth weight, having premature delivery, and having congenital anomalies such as bone malformations, and they can also have neurological impairments such as deafness and blindness. And majority of congenital syphilis and HIV cases occur in sub-Saharan Africa, but as I mentioned, this is not an isolated problem. The screening recommendations to treat HIV or to screen for HIV and syphilis are to screen twice, first during the first prenatal visit and twice during the third trimester in high-risk areas. As I mentioned, it's necessary for timely detection and treatment, especially with syphilis because it is curable, and if you catch it in the early stages, you can treat it with generally 1 dose of penicillin. And it's one of the few diseases that you can actually treat and cure with penicillin. Once you detect with HIV, of course, that involves a much more lifelong type of treatment. And national policies recommend comprehensive antenatal screenings and treatment involving partners, so not just treating the mother, but to also treat her partner so that she doesn't, once she's treated, she doesn't go back and become reinfected. Exposing the fetus to syphilis or HIV. And despite these screening recommendations and comprehensive guidelines, many pregnant women are still not obtaining these antenatal screenings. And also the pictures that I've included in this presentation are my own. And if you see any people in them, I've obtained their verbal consent as a disclaimer. Okay, so the first study I'll be presenting are factors that are associated with HIV and syphilis screening during first antenatal visit in Lusaka, Zambia. So we'll be looking at individual level factors. It is a cross-sectional study design, and it'll be focusing on the baseline period of the Preventing Congenital Syphilis study. And the population that was involved were pregnant women who participated in this Preventing Congenital Syphilis study in Lusaka, Zambia. So a little background about the Preventing Congenital Syphilis study. These two are some of our study staff that are going through the records. It's an implementation trial that was based in Democratic Republic of Congo and in Zambia. And it involved a behavioral multifaceted intervention going through training staff, health personnel, having a supply chain management portion, which looked at making sure that there were kits always in place so they never ran out, because stockouts are a common occurrence there. And also, they also did reminders for the healthcare providers, so putting up posters to make sure that providers it's always on their mind to screen when they go in and see a new patient. So this study particularly focuses on the 9-month baseline period. Okay, so about the baseline period. So women attending a first antenatal care visit at one of the participating clinics during April 13th, 2015 to January 10th, 2016 were approached for the study. And the trained study personnel presented details of the study and obtained informed consent. And only those who were able to give informed consent were eligible for this study. During the baseline period, we obtained a variety of data points, including demographic information, details of their current pregnancy, syphilis history regarding did they ever receive any syphilis treatment in the past, and then at the current visit, their syphilis screening status and their HIV screening status. There were 13 health facilities that participated in the baseline period, and they were all designated as urban health centers. So they were mainly located within the capital, which is Lusaka. And that's just a picture of one of the women's clinics. In terms of inclusion and exclusion criteria, so as I mentioned, all consenting women who were attending an antenatal care visit for the first time were able to be included. The first antenatal care visit needed to be within the baseline period, and it had to have been recorded within the Preventing Congenital Syphilis database at the Lusaka site. And we included women with complete data. The outcomes of interest, these are non-mutually exclusive outcomes. So we looked at obtained an HIV and or syphilis screening, and then we focused on those women that obtained a HIV screening and the women that obtained a syphilis screening. For the analysis portion, we used a log binomial and Poisson regression model with robust variance using an autoregressive covariance matrix. And the data is summarized as number and percentage for categorical variables. We present a crude and adjusted prevalence ratio and 95% confidence interval. And the prevalence ratios were adjusted for age, marital status, education, history of known syphilis infection, and previous pregnancy. And these were selected a priori based on the literature. In terms of the results, so overall within our study population, we had women who were majority were aged 20 to 34 years. We had 88% that were married or with a partner. In terms of education, they had completed greater than primary school, but had completed up to secondary school. And in majority, about 97% did not have a history of syphilis screening in the past. Among women with a previous pregnancy, many of the women without previous pregnancy did not have a previous abortion and or stillbirth, and they also did not have a preterm birth. So overall results, we can see that 95% of women obtained an HIV screening, 29% of the women obtained a syphilis screening, and 4% of women did not obtain either an antenatal HIV or syphilis screening at first visit. So looking at just HIV screenings, a majority of pregnant women, as I mentioned, 95% had obtained HIV screening, and it was majority of women across all levels of age, marital status, education, and history of syphilis infection and previous pregnancy. But then looking into when we compare the groups, pregnant women with a history of syphilis infection had an increased prevalence of HIV screening compared to women without a history of syphilis infection. Women who were greater than or equal to 35 years of age had decreased prevalence compared to women that were less than 20 years of age. And divorced and separated women had decreased prevalence of HIV screening compared to married women. And pregnant women with 2 or more previous pregnancies had a decreased prevalence of HIV screening compared to women without previous pregnancy in the past. So in terms of syphilis screenings, we found a very interesting finding. So we saw that about 29% in general did not obtain a syphilis screening at first visit, and that did also, it was about the same across the levels of age and marital status, history of syphilis infection and previous pregnancy. Majority did not obtain a syphilis screening. And when we compare within marital status, that was the significant finding in terms of women who did or did not get syphilis screening. Divorced and separated women had a decrease in prevalence of obtaining syphilis screening compared to married women, and widowed women without a current partner had an increased prevalence of screening compared to married women. So it was an interesting finding. Limitations of this study. So the data collection was not specifically designed for the purposes of this cross-sectional study. There could be recall bias as the study personnel obtain the data points, and there could also be social desirability bias among the participants as they are completing this form with a study personnel. The second study I wanted to present is on antenatal syphilis screening interventions in sub-Saharan Africa in general. It's a systematic review and meta-analysis. So now that we found that so many women are not obtaining these syphilis screenings, so how do clinics actually go in and improve their uptake of syphilis screening is what the aim of this study was. And there was a previous study conducted by Sarah Hawks and colleagues that came out in 2011, and it focused on the effectiveness of interventions to improve screening for syphilis in pregnancy. And this was the initial study, and it had studies from all over the globe, from Haiti, Mongolia, US, Zambia, Mozambique, South Africa, and Kenya. But these studies were conducted in the 80s and 90s. And so this study was an update to that previous study. In addition, there's been a lot of changes within the landscape of screening. We now have point of care tests are now the norm. And so I wanted to update that as well within this study. Okay. So we wanted to specifically look at interventions and intervention components that aim to improve the uptake of antenatal syphilis screening. As I mentioned, this is a systematic review and meta-analysis, and we searched 6 databases for this meta-analysis. In terms of inclusion criteria, so we only included studies that were written in English. The study population was restricted to pregnant women, either with or without their partners, attending an antenatal care visit. And the study needed to present original data that aimed to reduce this vertical transmission of syphilis involving screenings. It needed to also be conducted in sub-Saharan Africa. So with this study, we wanted to give a geographical focus to specifically sub-Saharan Africa. And outcomes of the study were related to screenings conducted at an antenatal care visit. So it couldn't have been outside that context. And comparative studies and randomized controlled trials were included. Other systematic reviews were excluded. And there were date restrictions because we wanted to make this kind of an update to that previous study. We did date restrictions of January 2000 to December 2017 for the searches. For the meta-analysis, we did random effects meta-analysis to estimate a pooled percent difference with a 95% confidence interval, and this was performed using MedCalc for Windows. So after going through all the searches, we also had a medical librarian who helped us with the crafting the searches as well. And we had 651 unique records. And from that, we filtered out about 57 we saw that we're eligible for full text articles compared when looking at the eligibility criteria. And from the 57, we ended up including 10 in our systematic review. So the summary of the included studies, there were 10 observational studies, no randomized control trials were included. In total, there was 131,986 pregnant women from 1997 to 2014. So that's when the study was conducted. And 4 studies looked at feasibility of implementing an intervention within clinics themselves, within the countries of Uganda, Burkina Faso, Zambia, and Tanzania. And there were 6 studies that evaluated the impact of a national level policy or antenatal screening interventions in Uganda, Kenya, Tanzania, Ghana, and Zambia. So because these studies were only observational studies, we used Robbins' I to evaluate for risk of bias. And the studies, there was quite a variation within the studies that were included. It ranged from low risk of bias to critical risk of bias. So the way Sarah Hawks and colleagues had looked at these components was they first divided these intervention components into 2 different sections, looking at decentralization of testing and treatment and improved case management. So not having one clinic do all the services, but enabling the smaller clinics, the local clinics, to be able to provide the screenings. And also, the other section was health system strengthening, and these were the components within each. It then further went down to the components of the intervention. So within this decentralization of testing and treatment and improved case management, we have rapid test, same-day treatment, partner notification, patient counseling, 3rd trimester test. And then within health system strengthening, did they train their staff? Did they have any quality control in place? Supply chain management, and supervision and monitoring of the process. So here are the 10 studies listed here on the right. And it's the ones that are highlighted in red. So at least within these 10 studies, they had included at least one component of the decentralization of testing and treatment and improved case management, and one component of the health system strengthening. And the ones highlighted or circled in red are the ones that majority of studies included as part of their intervention. So rapid test, same-day treatment, partner notification, patient counseling, and training of staff of how to conduct the syphilis screenings. So out of the 10 studies, there were 4 studies that included a pre-post test frequencies of syphilis screenings obtained among women during an antenatal visit. And you can see here, majority of and there were only 4, but majority of the 4, you could see that post the intervention, there were a higher number, a significant number of increase in syphilis screening, except for ET-DASA. It was evaluating a national level policy, and it actually showed a decrease in syphilis screenings post the intervention. So according to the author and according to their calculations, it wasn't a statistically significant difference, but as you can see, it did have a lower frequency. And when we pulled the data, I did a % difference, so post minus pre. And overall, it showed that if there was an intervention in place aimed at improving uptake of syphilis screening, there was an overall 40% increase in the frequency in the post. Okay. In terms of limitations, for this study, there's a possibility of not including eligible studies due to the search strategies that were implemented. Eligible papers before 2000 were not included in this review. There could be publication bias with this systematic review. There were, of course, individual paper limitations and biases that we couldn't account for that could have affected the reported findings, and in terms of this common percent difference of that 40% increase in uptake of syphilis screening with an intervention, it should be considered as an estimate, as we didn't include adjustments for the variety in sampling strategy employed by these individual studies. So in terms of public health impact, so these studies serve as kind of a preliminary step to identifying factors associated with HIV and syphilis screenings for prevention of congenital HIV and syphilis. And hopefully this will inform future interventions and healthcare staff who help to target pregnant women that are least likely to obtain HIV or syphilis screening. Okay, thank you.
Very nice presentation. Thank you. And we got that time for questions.
Okay. Yeah.
These are very important studies, but it's very difficult to understand your Zambia data without some context. What's involved in these screenings? What are the costs and the burden for the patient or mothers? If does literacy play a role in your respondents? And finally, why are syphilis and HIV screening separated and not done in the same location or time?
Ooh, many questions. Okay. So first of all, context. So this is done in the local Lusaka district clinics. And for this study, it was the baseline period, so it was as usual, as normal. And these women do not have to pay for an extra syphilis screening in Lusaka. I'm sorry, could you repeat your other questions?
Why are they not combined syphilis and HIV screening at the same occasion time?
Yeah, so generally it is combined in the sense that if you come for an antenatal care visit, it's policy that you do get an HIV test and a syphilis screening, but sometimes these facilities have stockouts usually stockouts of the syphilis screenings. They usually have the HIV screenings available.
So it's not the women's decision whether they don't or do have syphilis.
It's a bit of both. So they can opt out as well. Perhaps they think, and this is just me conjecturing, possibly that they think they're in a monogamous relationship and they don't feel like they need it. In general, the process is extremely long. They have to wait there very long to even be seen. There are lines, and so they want to get out as quick as possible. So it's a little bit of both on the facility level and on the individual level.
And eligibility criteria, do they require literacy of the women? And especially on the rural side, would women often not be literate?
So many of these women were literate because they had obtained yes, they're urban, yes. But if they didn't, if they couldn't write or something like that, we would get a thumbprint as for their informed consent. And to that point of the literacy point, we would have data personnel kind of asking the questions to the mother, so she didn't have to complete it by herself. Yeah. Mm-hmm.
Brian, and then Susan.
The finding that separated and divorced women were less likely to screen, and widows were more likely to screen, just has me searching for social causes.
Right. Well, me too. Yeah.
So could you say a little bit more about that?
Sure. So I would want to, like, after I saw that finding, I wanted to do a focus group, right, with these women who were divorced and married. I think so. I don't want to speak for the women. I'm not sure exactly what's going on, but I think that's definitely an area for more research. Yeah.
I was sort of, I was wondering, like, that generally we think of having some sort of partnership as like salubrious in general. Mm-hmm. But then these are two groups who don't have partners anymore.
Yeah.
And then it makes me wonder if, like, women who are widowed somehow get more support in other ways than women who are separated and were divorced, and if that might explain some difference.
Well, and also, why are the women widowed as well? You know, it could be that the partner passed away from an infection. That's one of my thoughts on it. But yeah, it would be a very interesting, like, focus group type study. Yeah.
Thank you for a very elegant study. So I think this was the baseline for an implementation trial?
Yes,
okay,
that's right.
Let me just shelve that for a moment and say, looking at your results, what would you like to do about it? What did you learn about an intervention that think should be done, or would you like to tell us about that the clustered implementation trial that was done, which maybe made a decision on the basis of your work? I'm not sure.
Yeah, so actually, yeah, no, absolutely. So actually with the Preventing Congenital Syphilis trial, the results are just published this month for Lancet Global Health, so you can look it up. It actually did find a significant finding with their clinic. So pretty much for the control clinics, they gave just syphilis testing kits, and so just supplies. And then for the the intervention, they included the reminders, so posters all over the clinics, hopefully reminding the patients to ask for it if they're not given the test, and also for the healthcare staff to also keep up on it too, and have that in the back of their mind. They also did staff trainings and included a supply chain intervention. And from my look through looking at the literature, it seems that there's a facility based problem in terms of, I think the stockouts are the real main cause for why these women aren't getting these syphilis screenings. And I think, so that intervention included them, for our study, it included having fishing boxes. They had like these tackle boxes, and they had the kits with the number of how much is in stock at the moment. And they had to keep updating it every midweek with the number, so they know exactly when they're about to run out and to call in and get more kits. So they did see a significant difference with that intervention and without that intervention. So I'd like to see that implemented more. And I think it's doable. I mean, so just giving them supplies isn't enough. You also need to include a behavioral training component. Yeah.
So it sounds like, or at least what I'm hearing, is that it's much more on the structural, clinical policy side than the patient side.
I think so.
Or do you think there is some patient separating whether I want a syphilis versus HIV, or is it really, the issue is really more at the policy clinic level?
I would say it's more at the policy level because it is kind of an opt-out situation, but you never know. I mean, with the women, if they're with their partners, they may not want to seem like I want to opt out of the test. I mean, it's a little bit of both is important to note.
That's great.
Right.
Yeah, so thinking about that, even, I guess if you address that issue, you mentioned that there's the issue of people having to wait a very long time or all day. And what is it that, I guess, causes delays, or how long are they actually there for?
Oh, wow. Yeah, so they are there from like 6 in the morning to get out early. I feel like cause of delay, there's not enough staff is part of the problem. It's about 2 people for like 50 people in the room. So everyone, and each of those women need to get a battery of tests done. And so it's understaffed. It's a lot of people. It's a crowded room. Some of these women just don't even want to wait and for these tests, and they're like, why? I mean, and they're hungry and they're standing there. So there's a lot of factors involved with it. Yeah.
So if I can, we have a couple minutes. So you go, and then I have a quick one.
I was just thinking about like the whole time and the waiting. I'm wondering if something like at-home syphilis testing like would work instead, or just what you think
that would be
home HIV testing as well.
That would be really cool. Yeah, absolutely. If they were able to if they were able to contact these women at their homes, that would be I think it would be really good. Yeah, but it's just that in terms of turnover of residents, and these women some of these women don't live in actual homes. They live in like these towns with like huts, and so there can be a lot of turnover in terms of residents. But it's a good idea to kind of go in and just do immediate self-testing.
Or like I'm just wondering, like sending women home with their care. I just feel like recently the WHO is like they're putting out new guidelines for what they're calling it self-care, but the idea is that you're trying to encourage people to take some of this type of thing, like to do some of these tests for themselves at home, like so at-home pregnancy, but at-home HIV, and I'm wondering if at-home syphilis could also be another strategy.
No, that's a great idea. And also on that point, one of the delays is also women not obtaining their results. They're sent to the lab. Sometimes it gets lost in the lab. And so it would be nice if they could get a test that told them exactly how to do it and like their results within 20 minutes. That would be great.
And one example I know of work being done, particularly in the U.S., but maybe other places too, is with MSM and at-home STI screening test. And there's a whole program of doing that. You can order it online, you can get them, you can do them. So I think that could be applicable to different populations. If I'm recalling correctly, your slide about the outcomes, the pre and post, it looked like the range was from 18% to 100%.
Yeah.
Right?
Yeah.
So what kind of analyses can be done or are being done to, I mean, first of all, to look at the success, like what were the factors associated with movement towards 100%?
Sure. I think it's the quality control and the monitoring portion that really stood or put those more successful interventions apart from the other ones. Having a lot of, so the one that by E.T. Dasa that went actually lower in post, that they attributed that to poor data collection on their part, and they used registry data on it wasn't a intervention that they actually implemented. It was a national rollout of point of care tests. So I think it's collecting good data, honestly, and that's all we can do is analyze those.
Last one.
Does Zambia have any advocacy groups that are against medical treatments from Western sources because they suspect to compromise pregnancies or that sort of thing?
For my time in Lusaka, actually, no. There's a lot of outside agencies that are coming in, helping out, and they're very welcoming to anyone that can help in NGOs. Yeah.
Okay, thank you for a great presentation and discussion.
Thank you. Did you just hold this or did you strap it on? I just hold. Yeah, I'll go over there.
Wherever you like, wherever you're comfortable. So our second presentation, we're pleased to have Dr. Yzette Lanier, who got her PhD in psychology from Howard University. She's a developmental psychologist and assistant professor at New York University's Rory Myers College of Nursing. Prior to her appointment at NYU, she completed postdoctoral fellowships in the Division of HIV/AIDS Prevention at CDC and the Center for Health Equity Research at the University of Pennsylvania. Broadly, generally speaking, her research seeks to improve the health and well-being of adolescents to young adults. For the past 10 years, her work is focused on reducing HIV, STIs among Black and Latino youth. She currently serves as a PI of a $1.2 million CDC-funded study, congrats, which examines relationship dynamics and the use of HIV prevention methods among young Black and Latino heterosexual couples. Thank you for being here. Welcome.
So good morning, everyone. It is truly a pleasure to be here with you today to talk about some important work that I'm currently doing, which looks at the context of adolescent and young adults' intimate or romantic relationships as a HIV/STI prevention strategy. So in the U.S., one of our national priorities is to address the health needs of young people, right? And so as you can see, according to Healthy People 2020, one of their goals is to improve the healthy development, health, safety, well-being of adolescents and young adults. And so one reason for this focus on the health of adolescents and young adults is just given the critical period of adolescence and young adulthood. So by a show of hands, how many people either have teen kids, work with teen kids, or just remember that developmental period. So as you know, right, that is a time of significant change, both cognitively, physically, emotionally, socially, so on and so forth. And with all those different changes come two different things. One is a time of great opportunity for growth and development, but it also is a time for risk and vulnerability. And because of that vulnerability, adolescents and young adults are often at risk for poor health outcomes. And one such example is their sexual and reproductive health. And so as we see here, if we look at HIV nationally, we see that about 21% of all new HIV diagnoses in the US are among youth ages 13 to 24. And this is quite alarming, but if you look down at the next graphic, you see that there's great disparities in our HIV care continuum. So for example, only 56% of all youth who are currently living with HIV have actually received an HIV diagnosis. In addition, of those youth, only 27% have actually reached viral suppression. And so this is important and has great implications and serious implications for HIV transmission. When we look at STIs, we see similar findings with youth ages 15 to 24 who making up about half of all new STIs each year. And then when we look at HIV and STI prevention uptake, even though that we found some very great HIV biomedical interventions like male-female condoms, HIV STI testing, and PrEP, we see that the uptake of these medical interventions remains suboptimal. And so it's for these reasons that there's been this national call, right, to direct our efforts at reducing new HIV infections among youth, particularly those who are most affected, are disproportionately affected. And indeed, we see that there are these great disparities among youth. As you see, Black and Latino youth comprise the vast majority of HIV infections. And so with that being said, I want to make a statement that the research that I currently do does focus on Black and Latino youth, which is in line with our national efforts. So I would be remiss if I didn't talk about that we have done a lot of great work, that there has been significant progress and a number of different strategies to address this issue, one of which is the development of these HIV prevention behavioral interventions. A number of researchers have developed these interventions, and indeed we found that these interventions have demonstrated efficacy in reducing sexual risk. One note about these interventions is that the majority have focused on individuals and individual level determinants. With that being said, while they've been shown to be effective, there's limited evidence that the effectiveness of these interventions is sustained over time. And so given this limited evidence of sustained change over time, in addition to these consistent rates of high HIV infections among youth, there's been this call for new HIV interventions, a call to move beyond individual level determinants and focus on the broader context in which sexual behavior occurs. And so I suggest that one reason for the limited sustainability of these individual level behavioral interventions is that they continue to not consider the context in which sexual decision making occurs. And that's the relational context, our intimate or romantic relationships. And so we know that intimate and romantic relationships are important in general across age groups, but however, they're particularly important for adolescents and young adults. For one, they're common and highly valued during adolescence and young adulthood. Two, they're one of the strongest predictors of youth engaging in sexual activity. So a research study that I have previously conducted found that youth's sexual date who engaged in sexual initiation, the main reason was because they were in this romantic relationship or wanted to be in a romantic relationship. In addition, we found that relationship dynamics are associated with uptake of prevention methods. And when I talk about dynamics, I'll share a little bit about that a little later, but I'm talking about the context, if you will, of the relationship, how it's structured, and the quality of the relationship. And so with that being said, couple-based strategies may be a promising HIV prevention strategy. Indeed, there's been different research and systematic reviews that have found that couple-based interventions are effective in reducing sexual risk and increasing uptake of prevention methods. However, there's a number of limitations. One, there's not enough research specifically on youth as well as heterosexual youth. So while the HIV epidemic primarily burdens men who have sex with men, heterosexual youth have been largely neglected, but specifically young men who just haven't been looked at and considered, even though they're at risk. In addition, these HIV couple-based interventions have not focused on the uptake of combination HIV prevention methods. So oftentimes these behavioral interventions will talk about the uptake of one prevention strategy, whether that's condoms or HIV testing. But as we know, combination prevention methods are a high impact approach to reducing new HIV infections, particularly in young couples. And so one suggestion would be the development of these couple-based interventions to increase the uptake of combination HIV prevention methods, and this being an effective strategy to reduce new HIV infections. However, before we can get to that point, more research is needed on how relationship dynamics as well as individual factors influence use of combination HIV prevention methods. And so the goal of this study, this exploratory qualitative study, was just that, to first assess young Black and Latino heterosexual couples' use and attitudes towards combination HIV prevention methods. This is an area where we still don't have a lot of information about, and so more research is needed. In addition, we need to examine how individual and relationship level factors influence use of combination HIV prevention methods. So the current study was funded through this CDC Career Development Award called the Minority AIDS Research Initiative, or MARI. MARI is a larger multi-phase mixed method study called Project Yes. And the aims of Project Yes are threefold. So first, to identify strategies to identify, recruit, and retain young Black and Latino heterosexual couples. Two, to examine the interplay between individual factors and relationship dynamics on use of combination HIV prevention methods. And then to actually develop and pilot test a scalable, culturally tailored, and age-appropriate couples-focused intervention to enhance uptake of combination HIV prevention methods. And so the first two are the formative research stage, and that will inform the development and pilot testing of this intervention. And so this is a guiding conceptual framework, and as you see, there's a lot of information there, right? And so that was actually one of the challenges of the study, but it speaks to the importance of looking at both individual level factors and relationship factors. For the proximal or individual level factors, it was a synthesis of major theories of social behavior that have been applied to understanding health behaviors. So those would be the ones we know: social learning theory, health belief model, and reason action model. In terms of our relationship factors, basically I did a review of the literature just to determine what the most important relationship dynamics were. And as you can see, there's two components of relationship dynamics. First is the structure. How is a relationship structured? And that speaks to the type of relationship. Is it serious? Is it casual? The length of the relationship, age discordance as well as race discordance, sexual exclusivity, and then sexual experience. For quality, it's those other factors like trust and love and commitment and communication and power. But both components are important in terms of looking at its impact on use of combination HIV prevention methods. So for this study, we recruited young couples who were in reciprocal romantic relationships. So essentially, they both had to claim each other. And one couple member had to meet the following eligibility criteria. They had to identify as Black or Latino, be between the ages of 16 to 24, and currently reside in the South Bronx. And we focused on the South Bronx because that is an area of geographic HIV vulnerability. And so we wanted to focus on high-risk youth, high risk in the context of where they lived. We use both active and passive strategies to recruit our sample. However, the main recruitment strategy was street intercept, so approaching young couples or youth on the street. The qualitative study, or the interview session that all youth participated consisted of completing a demographic and sexual behavior survey, a 60-minute semi-structured interview session, and a 60-minute dyadic interview. For the data that I'm going to present to you momentarily, we focus only on the demographic and sexual behavior survey, as well as the individual interview. Within that individual interview, we ask young couples about their individual factors, as well as their relationship dynamics, and how that influenced their use of combination prevention methods. These interviews were all recorded, transcribed, and coded by a team of 4 people. So in terms of the analyses, we conducted simple frequencies to examine the current use and type of HIV prevention methods that youth were using currently, as well as content analysis to identify how individual and relationship factors influence use of combination HIV prevention methods. And so in terms of characteristics, we see that there were equal percentages of Black and Latino youth. Most youth were between the ages of 18 to 24, and most were in more serious type of relationships. When we look at current HIV prevention use, we see that approximately 63% were currently using some form of HIV prevention method. And as we go down, we see that that could range from male to female condoms, STI testing, HIV testing, or PrEP. And it should be noted that youth could be using more than one prevention method. So our first finding looked at current use of combination HIV prevention methods. And what we found was that use of combination HIV prevention methods was fairly low. So only 28% of youth, and this is out of 29 individuals, only 28% of youth were using 2 or more HIV prevention methods. And then when we looked at the different type of combination prevention packages that they were using, we see that the majority were using a combination of HIV STI testing. The second finding speaks to attitudes towards these combination HIV prevention methods. And as you can see, youth held positive, negative, and neutral attitudes. So overwhelmingly, youth felt really positive about a combination prevention package. They felt that it was effective. They felt that it would increase their safety. One male participant actually referred to it as a super shield because he felt that it would give him even that more protection when he engaged in sexual intercourse with his partner. And they also noted, which I think is important, that it was accessible. So communities like the South Bronx often are thought of where youth may not have access to services, but youth in our sample said it wouldn't be hard for them to access these services and these prevention methods. However, despite holding fairly or overwhelmingly positive attitudes, there were some negative issues or negative attitudes. The first was that it was time intensive. So youth, particularly when it came to HIV, STI testing and PrEP, felt like it would take a lot of time so even though service was accessible, they would have to still get there, they would have to wait. They didn't like the idea of having to get a prescription for PrEP, meaning having to go to their healthcare provider to get this medication. The second was this fear of potential side effects, and that was specific to PrEP. One thing I didn't highlight on one of the previous slides was that none of our participants were using PrEP, as well as none of our participants actually reported knowing about PrEP. And so that might be where this fear of potential side effects was. So specifically with PrEP, in using a combination prevention package, they weren't sure what the side effects would be.
Could you remind us of when these data were collected?
So when?
Yeah.
About a year ago.
Oh.
So fairly recently. The third negative attitude was this fear of consequences for a relationship. So many youth felt like two things. One, introducing the use of combination HIV prevention methods at this stage of their relationship would have their partner have some questions, either about what they were doing or what they thought of their partner. And so they felt like, given their relationship, they couldn't introduce it at this particular stage. And then there were also neutral attitudes, and the neutral attitude really had to do with this low perceived HIV vulnerability because of their relationship dynamics. So many youth felt like, hey, this wasn't applicable, or this isn't applicable to my particular relationship, given trust, given commitment, given monogamy. And so for our third finding, we developed relationship profiles. So we analyzed the qualitative data and we found three kind of distinct profiles. The first was decreased use of combination HIV prevention methods over time, or I guess because we trust each other. The second group was consistent use of prevention methods, or my health is a priority. And then the third group was inconsistent use of combination HIV prevention methods, or I trust my partner, but you never know. And so we like to call group 3 the confused group. So for group 1, these were individuals who reported decreased use of combination HIV prevention methods over time. One thing I want to note, so for the study, we recruited, this data consists of 23 couples, so 46 individuals. We analyze this data not at a couple level, but at individual level. So this is of 46 individuals. So for group 1, this is our decreased use of combination HIV prevention methods over time. And so as you can see, these youth are characterized by a number of different relationship and individual factors. So they have high partner trust, high relationship commitment, longer relationship duration, but negative attitudes towards condom use. But as we analyzed the data, what we found was it was really this high partner trust, this trust in that partner that really gauged whether they were using prevention methods. And so as you can see from Samantha, she says, I wouldn't say that love is the reason why I'm not using any of these HIV prevention methods. I feel like it would be more trust, but not love. I mean, I do love him, but that's not the reason why I don't use any of these methods. And so it was really the trust. The interesting thing about this group was that they either were not currently using any methods, or there was a clear discontinuation of methods over time, particularly condoms. So our second group, they had consistent use of combination HIV prevention methods. And so similar to our first group, you see that they had high partner trust, they had high relationship commitment, but they had a high priority on their individual health and safety, as well as low HIV knowledge. They also had high habitual HIV prevention use. So using prevention methods for this group was more of a habit. And so for this group, it was really this priority on their health and their individual safety that really drove their consistent use of combination HIV prevention methods. And in fact, part of their health and safety is my priority was fueled by their lack of HIV knowledge or their misinformation. And so Rindcy says, we trust each other. We know that we're not with other people, but to always be on the safe side. You never know what happens. I don't mean, oh, she's going to ever cheat on me. No, I just mean, you never know what could happen with your body, what your body can produce or whatever, because we don't know much about our body. So in Rindcy's interview, he consistently talked about how, you could just develop HIV, that it wasn't transmitted through like sexual contact or other methods, that your body could just happen to produce HIV. And so his focus was that he did trust his partner, but he always wanted to be safe. But that safety to some extent was fueled by his misinformation. So the third group was our inconsistent use of combination HIV prevention method folks. So similar to our other groups, we still see that there's high partner trust. However, there was low habitual HIV prevention use, as well as low relationship trust. And so the real driving factor, even though there was low habitual HIV prevention use, it was this low relationship trust. So these folks said, hey, I trust my partner. I know that he or she isn't cheating, but they had this mistrust of relationships, of men and women. So it wasn't their partner, but distrust of their relationship, if that makes sense. And so, as Lynn says, mine's more of a you never know. Yeah, let's do that because you never know. That's where mine's kicking in. But maybe for some people it's trusting. I don't trust him. Let me go get tested. For me, it's you never know. If I do happen to get tested and something happens, then hey, I know you did this, that, and the third. So again, everyone in this group said they trusted their partner, but they had low relationship trust. Another interesting thing about this group are two things. So one, that they often use testing to confirm their commitment, and even if they didn't share their results. So the fact that their partner was willing to get tested to them confirmed that, oh, they're monogamous. This inconsistent use of prevention methods, we didn't get a sense in terms of when they did it or what. Sometimes they would use a number of methods, sometimes they weren't using anything. It just kind of varied. So our findings suggest that there's overwhelmingly favorable attitudes towards use of combination HIV prevention methods. However, young Black and Latino heterosexual youth in romantic relationships reported limited current use of these combination prevention methods. Our findings suggest that current use of combination HIV prevention methods was influenced by an interplay of individual and relationship factors. And I think that's really important, right? Because oftentimes in research, we do a either or. But this suggests that's not either or. It's not just individual factors. It's not just relationship factors, but it's and both. It's both of them. And both of these factors need to be considered as we talk about youth and think about their use of different prevention methods. Moving forward, we'll start doing couple level analysis and see how one partner's relationship dynamics or thoughts influence the use of prevention methods of their couple member or their partner. And two limitations of the study that I want to note. One was the impact of birth control. So we didn't look at that. So we asked, but we didn't analyze that with this data, and it didn't come out in the qualitative interviews. So because I work in a college of nursing, I've become more thoughtful in terms of the clinical considerations, and I think these findings do have major clinical considerations. One of which is that healthcare providers play a vital role in encouraging adolescents and young adults to use combination prevention methods consistently. Many people reported getting tested, but for the number of people who talked about getting tested and getting tested regularly, it was surprising that their healthcare provider hadn't mentioned packages like PrEP. So I think healthcare providers play an important role, and I think healthcare providers should continue to have ongoing conversations with adolescents and young adults about the most optimal package for them based on their relationship status. So I think one interesting finding from this study is that in thinking about the development and implementation of couple-based HIV prevention interventions is that it's not just one size fits all. You really have to understand where individuals are, not only within themselves and their thoughts and attitudes and beliefs, but also where they are in their relationships. What that means for healthcare providers is they have to have ongoing conversations with youth because relationship status changes. And based on this change of relationship status, it might be a change of the appropriate or most optimal combination HIV prevention package. And then thinking about these discussions that healthcare providers should have. So again, often we focus on the individual, but maybe it's important to have more couple level discussions where healthcare providers can come talk to the couples together to have both members discuss what works for them. And so I conclude with acknowledgement. So it really does take a village to conduct couples-based research. And so I want to acknowledge my amazing CDC Mari team as well as my Project Yes team. And that's it. Thank you.
Another great talk. Thank you. Yes, we have time. Discussion. Nadia from Zaganisa.
I really love this. I feel like this is like, I did something kind of similar in my research. This is like the qualitative. These are all the questions that I wasn't able to get from the quantitative interviews. I really love that.
Oh, we should collaborate.
So I guess the question I have, and something that I kind of struggled with, is I feel like there are different views on whether couples-based interventions make sense. And in particular for young people, because their relationships are so dynamic and also they're short, they're shorter, they break up, they get back together. So I was wondering what I didn't catch, or I didn't remember how long the average relationship was.
Yeah, so they were longer. I don't know if you can go back. Can I go back? Oh, I have it here.
And like, do you know, like, are they consistently together the whole time, or are they kind of like on and off?
So we asked those questions. I haven't analyzed those data yet, but that was something that, so the next part of this, the first part of this study was a qualitative. The next phase is a longitudinal prospective survey, and I'll be following couples over 6 months. And so that's been one of the concerns. Are couples going to stay together? From our phase, I'm going too far, sorry. Our phase 1 data suggests that their relationships are long. So we see that are fairly long. So 60% were in relationships more than 12 months. Now, I do need to analyze this. So the sample ranged from, so with couples-based research, you have the index participant and the nominated partner. For our study, the index participant had to be between the ages of 16 to 24. Their nominated partner could be of any age except if the index participant was a minor. So there were some considerations with respect to that, which made things challenging. But to your point, one of the analyses we want to see are these folks who are in relationships more than 12 months are older couples, or are they also our younger couples? Because it may be our younger couples, 16, 17, 18-year-olds who are having those more short-term relationships.
And then my other question is, like, I see 93% categorize their partner as boyfriend, girlfriend, but that can be such a broad category. So like what I found is like that label means all sorts of things in terms of both quality and also kind of the risk behaviors in the relationship. So do you think what do you think of that term as a partner type?
So I think it's terrible, right? So I don't think even as adults we really know sometimes. I don't know. But so to that point, so what we did for our next phase, so this study was, I think we have some great findings, but it was such a learning opportunity. Doing couples-based work. I always kid my team. I said, had I known then what I know about couples, my grant proposal might have been different. But seriously, so what we did, so I agree with you that what does a boyfriend, girlfriend, what does talking, what do those terms mean? So in our next phase, our survey, we actually asked these, but then we allow youth to actually write in and then give a description of what that means. So hopefully we get more data on what these different type of relationship statuses are.
Well,
thank you for this great talk. It definitely speaks to me as someone who's a former incarnation my question is about, let's see if I have it's your third finding. You're looking at the couple profile. And I didn't quite, I wasn't quite able to follow. You talked about how there was high partner trust, and then there was low relationship trust, right? So I was wondering if you could just kind of elaborate on that a little bit more, because I guess my question is, are they seeing their partners as the exception to sort of the general belief about relationships, or how are they?
So we're still trying to tease through that. So yes and no, right? So they consistently, strongly said that they trusted their partner, but it was this sense of, I don't trust men or I don't trust women. But if your partner is a man, then to some extent you would think that does he fall into that? Or if your partner is a woman and you don't trust women, does your partner fall into that? They adamantly said no. But it's interesting because they would continue. These are the folks, when we're talking about prevention, they were consistently testing, but not because they were testing as a confirmation. Is my partner cheating? So we're trying to tease out that a little bit more. It
makes me think is also, okay, so I trust my partner, but I don't trust other people around my partner. Right? It's like, I trust my partner, but like I can't trust somebody else because you know how they are.
Yeah, yeah. That did not come up. So they didn't use those terms. Yeah, that's true.
Things happen.
That's true.
I trust my partner, but things happen out there.
And you never know. So that was the phrase. Yep. Yeah, that's actually a really good point. This idea of you never know came up in every interview for this group. So this idea of, yeah, I trust my partner, but you never know maybe how other people are.
Right.
This is really great. And I thought it was so interesting that most people only use one method of prevention, and it tends to be testing.
Mm-hmm.
And these are young people who are willing to bring in their partner and talk to you about it. So you would think that it would be higher among that group than in general young people. So I'm happy to hear that you're doing this survey so you can sort of follow people who you might not be able to reach by recruitment. If you want to say anything about that.
Yeah, so we're excited about phase 3 too, our phase 2, the prospective survey, because what it allows us to do is to track youth over time and not only see a difference or a change in their sexual behaviors, potentially a change of their use of prevention methods, but how your relationship dynamics change across time and how that change across time in your relationship may change your use of prevention methods. So we see that there's a change across time, but now in the qualitative interview, right? But we'll actually get to see more like how the relationship dynamics influence that change in real time.
I realized there's a question in there too. Another question. Sorry. That since these were folks who were willing to talk to you with their partner or knowing that the partner was going to talk to you too, what's your sense of how they talk about other people's relationships? That other youth who may not have been willing to come talk to you, if they have any perspective on those dynamics?
Say more.
Do they say like, this is how it is in my relationship, but what I see in other people's relationships, people who might not have been willing to come talk to you, but they might still have a perspective on youth in general and their relationship dynamics?
Yeah, so we didn't get that in this, in the qualitative, but in the quantitative, what we're doing is, so we are asking about their attitudes and beliefs, but then we're also asking about other people. So we're asking about their partners, but we're also asking about peers. So do you believe peers would think it was good to use a combination prevention package? Do people in your group, are they more or less like you? So we get a sense of if they're saying they use prevention methods, but their friends don't, then they're different. We're asking about families as well. So would your families, would your parents be okay? How would they feel about a prevention method? So we'll get some of that in the survey.
Where does pregnancy prevention fit in? Is that discussed or in the mix or?
So we do ask about current pregnancy. We ask about pregnancy intentions because that definitely influences your use of prevention methods, or HIV prevention methods. For our intervention, no. And that's a really good point.
That's not what I want to say.
Okay, we got Jorge next.
Yes, I have a comment and a question. So my comment is about the conversation we're having about trust. People see trust in the relationship just in general. And I guess for me, it makes me think of, what are their reference points? So like where are they getting messages about how relationships are supposed to be? And then where do they see what relationships are actually like? So I'm sure there's familial scripts and cultural scripts and how that's informing the way they think about how they define relationships.
Yeah.
I think it should be how they are in reality.
Yeah. Yeah, we did get in some of the interviews this idea of what a healthy relationship is, and that's something we want to explore more. And as we develop the intervention too, I think that's going to be a key point, because a lot of youth did talk about, so two things. One, what was a healthy relationship, not knowing what that specifically was. Two, a number of females in particular talked about experiencing intimate partner violence. And so this idea of, to your point, what a healthy relationship is, do they know, what are they seeing in their, experiences, day-to-day experiences, I think is really important. We somewhat captured that, but we do ask more of that in the survey.
And then I just had a question. It was actually more about, really curious about your recruitment strategy.
Oh.
And like the Sergievsky part, just like,
Yeah. So I have a paper that is near final that I'm trying to submit in the next week or two, specifically about recruitment. So I learned a lot. What I can say is I'll tell you what happened, and then I'll tell you our next steps, some strategies. So we actually ended up with an N of 23. The way our study worked was we would approach the index participant, and then we would have to screen them. And then if they were eligible, we would screen their nominated partner. It worked great if the nominated partner was actually there. If not, trying to get in contact was difficult. I say all that to say we screened over nearly 400 index participants to get to the N of 23. Now, part of it was 1/3 of the people that we screened said that they weren't in relationships, or current romantic relationships, but I think twofold. So one, the eligibility of making sure the index participant meeting the eligibility criteria, that reduced a number of people being able to participate. So we've changed that in phase 2, where it doesn't have to be the index participant, but at least one member of the couple should be meeting these eligibility criteria. The other part was getting the nominated partner in. And so some strategies, particularly if they weren't there on site. So we've developed a number of different strategies. One, we refined our recruitment materials to make it more interesting to the nominated partner so they could be excited and really kind of engaged in the study. 2, we implemented a number of different recruitment strategies. So if we meet you on the street and your partner isn't there, because of IRB, we can't give the nominated partner's contact information. But what we can do is the partner can FaceTime their partner, and if available, and if they're willing, we can screen them. So those are some methods that we're doing. I think those 2, really engaging the nominated partner to participate, because oftentimes we recruit the one person and we say, hey, you go recruit your partner in, but what motivation is it for the nominated partner?
I forgot about Philip, so Philip and then Susan.
Okay, thanks. Yeah, that was really great. Thank you. It made me more of a comment. It just made me think about the way, that I really like how you introduced the concept of adolescence, and then some of the qualitative work that you're doing in terms of, how adolescents they don't necessarily, maybe it can inform the way we approach adolescence. Mm-hmm. So it's not necessarily thinking that we want to, if we think about ourselves, for example, I guess I'm still formulating this. Who in this room would want to hear that your partner is unfaithful or untrustworthy? Mm-hmm. Right? So when we think about messaging, I think you can also look introspectively and think, okay, well, it might be more receptive. We can just talk in general. Mm-hmm. The world is a kind of hectic place. So I think that's a really good, interesting, and useful finding, and especially relevant for adolescents who, we have these tropes of adolescents they don't know, this isn't going to be your lifelong partner, so they deal with that a lot. So I think from a health professional perspective, they might shut down and be less open. So I think it's more of a comment that is really useful and important finding for us all to keep in mind when we're recruiting this kind of population or working with them, that we want to think from this type of perspective instead of villainizing their partner. So I just appreciated that.
Yeah, thank you. And I think it speaks to, right? So it was interesting because it speaks to, on a level, youth thinking that they're in a monogamous relationship, they trust their partners. You would expect them not to be using different prevention methods. That's what adults do, right? But is there a different level of vulnerability because of youth? So thinking through that from a research perspective, from a clinical perspective, how do we have those discussions? How do we change the message? And I think one of the big things about the study that we found with these 3 different profiles is maybe our messages need to differ based on who we're talking to. So again, not this just one size fits all message, but depending on asking the questions in terms of where they are and what their beliefs are, you have a different method, you have a different approach. If health is my priority, then I frame it very differently than if I trust my partner and I know he's monogamous or she's monogamous.
Last question, Susie.
Thank you. Thank you so much. I wanted to
question a little bit the idea of HIV testing being a prevention strategy.
Yeah.
And the interesting thing about it is, for an individual, it's not.
Mm-hmm. Correct.
But in the context of a couple,
Correct.
it could be. So if you frame it as mutual joint testing, if I know that my partner is HIV negative and STI negative, then that is a prevention method. And vice versa, if my partner knows that I'm negative, that's a prevention method for my partner. But if it's not framed that way, I think it's misleading. And, we did some work on this population a number of years ago, and already people were saying, I know I'm safe because I get tested.
Right.
It's kind of like, well, whatever I was doing then, and I didn't get infected, so it must be okay what I'm doing. And that is kind of magical thinking.
Yeah.
I think it's important to question that.
No, I agree.
To punch the balloon a little bit. But if it's done together, it can be very different.
I agree. No youth and we asked that. No youth reported being tested together. They knew oftentimes that their partner was getting tested, and they would have conversations about it, but no one got tested together. But I think that actually is a really great strategy. Yeah. Thank you for that. Thank you.
Thank you, and I want to thank both of you.